Hello, I'm Dr. Beverly Vaughn, and welcome to Menopause and You Chat with a Physician. Today, our guest is Dr. David Holtz. Dr. Holtz is a GYN oncologist at both Lankenau Medical Center and at Paoli Hospital. Our topic today is the Pap smear. Thank you for joining us today, Dr. Holtz.
Thank you for the invitation.
I just wanted to first go over for the audience what a Pap smear is and what it screens for.
A Pap smear is a scraping of free cells off of the cervix of the uterus, and the cervix is that part of the uterus which is extending into the vagina. Pap smears do not look like for ovarian cancers. They don't look for cancers of the lining of the uterus. They really just look for precursors to cervical cancer, but they've been very, very successful. Since their introduction in the early 1900s, the number of deaths from cervical cancer in the United States has dropped significantly from over 60, 70,000 a year to now we have less than 3,000 deaths from cervical cancer a year in the United States.
So I'm glad that you mentioned how long Pap smears have been around, because it really has been a very, very long time. And when they first started, and up until fairly recently, it was an annual event where the woman came in and saw her provider and got a Pap smear taken. But now the frequency of Pap smears has been decreased, so the interval between them is a little longer. Can you explain how that came to pass?
Sure, and this is very confusing not just for patients but also sometimes for their physicians, because in the last 15 years we have had an explosion of information about the precursors for cervical cancer, why do cervical cancers occur, and what should we do with mild abnormalities of the Pap smear. So the standard teaching up and until really the last few years had been that a Pap smear is an annual event. Now we know that women in their 20s can safely have a Pap smear every third year as long as they're normal. And from ages 30 to 65, they can either safely have just a Pap smear every 3 years or a Pap smear with HPV co-testing. And HPV is the human papillomavirus. That is the causative agent for most of our cervical cancers. And with co-testing, you can extend the interval between Pap smears to once every 5 years.
So it sounds like two things went on. One, the understanding of the development or progression of pre-cervical cancer changes, and also the addition of the co-testing. Is that correct?
That is correct.
Would you explain a little bit what the human papillomavirus is and what its role is in cervical disease?
HPV stands for human papillomavirus. And human papillomavirus is part of a very big family of viruses that cause warts in all kinds of different animals, not just people. Human papillomaviruses are a smaller group that affect the skin cells of humans, and they really can affect the skin cells anywhere. Mouth, the skin, the anogenital tract. The human papillomaviruses that your gynecologist is testing for specifically target the human anogenital tract, the vagina, the vulva, the cervix, the perianal region. And they have a very specific attraction to these areas. Most of these viruses are simply going to cause warts or no symptoms at all, and they will go away on their own. There's a very small group of these HPV viruses that are oncogenic, meaning they have the potential to cause changes that will make the cells precancerous or cancerous. Now, you do have to understand that even if you are diagnosed with one of these high-risk human papillomaviruses, they have a very small chance of going on to create precancers or cancers. So the most common human papillomaviruses to affect people are HPV number 6 and 11. And these predominantly cause warts. They will never, ever be implicated in cervical cancers. There's another group of approximately 15 high-risk oncogenic human papillomaviruses that are tested for sometimes alongside a Pap smear, sometimes separately, which can indicate somebody may be at risk for developing the precursors of cervical cancer. And these high-risk human papillomaviruses, HPV viruses, are the ones that are responsible for the vast majority of human cervical cancers.
So would you say then that the advantage of doing co-testing, adding HPV testing to a Pap smear, is a better predictor in a particular patient of what her risk is of developing either precursor to cervical cancer or cervical cancer?
Absolutely. It has two advantages. First, if a woman aged 30 to 65 is negative for both Pap smear, meaning the cells that the pathologist is seeing are normal, and they are also negative for human papillomavirus, we know now, based on good prospective long-term studies, that the risk of developing precursors to cervical cancer or a cervical cancer in the next 5 years is approximately 4 in 100,000. It's a similar risk to a man developing breast cancer, to put it in perspective.
That's pretty small.
It's a small risk. If, however, you have mild abnormalities of the Pap smear, what we would call atypical squamous cells, which is the most common abnormality of Pap smears, which is a pathologist telling you they think something's wrong, but they can't really put their finger on it. If you get one of these Pap smears and your HPV test is negative, we know your risk of developing a precursor to cervical cancer approaches that of having a normal Pap smear. So then the interval can, again, go several years, 3 years, before having another test done. Human papilloma testing, however, is not indicated for women between ages of 20 and 29 because the incidence of HPV infection is very high in younger women, and most of those women are going to clear it, sort of similar to a cold virus. Okay? You're not going to stop kissing because of the cold virus. Human papillomavirus is just a side effect of sexual intercourse. And most women are going to get the virus. They're going to cure themselves of the virus without any intervention, and it's never going to lead to cervical abnormalities. But we know that after age 30, if you have HPV virus, that can be an indicator that you may be somebody who has not cleared the virus, will not clear the virus, and can go on to develop a cervical precursor to cancer.
So you can really target your recommendations to the patient by doing this.
The advantages are huge. Many fewer women will go for biopsies and testing because of abnormal Pap smears with co-testing with HPV.
There's a new guideline that women who are over 65 don't require Pap smears anymore. And I know that there are women who find that a little unsettling because they're used to having that done on a repetitive basis. What is the scientific reasoning behind stopping at age 65?
The rationale is we, again, have good long-term follow-up studies of women who were negative, have normal Pap smears for a decade. And you have to fulfill very specific criteria to stop doing Pap smears. So a woman over, say, age 65 who is not engaging in new sexual partners, which would subject her to new papillomaviruses, HPV viruses that she has not been subjected to before. The woman has to have documented 10 years of normal Pap smears in the preceding decade and can never have had a high-risk biopsy, CIN2-3, a high-grade cervical intraepithelial lesion, or a cervical cancer. So if you meet these criteria, we know that these women have a very low risk after age 65 of going on to develop a precursor to or an actual cervical cancer. And that risk, again, it's not that the risk is zero. It's that the risk is so low, it may not be appropriate for us to test everybody. So one of the other changes that has occurred in the last 12 years is the realization that with our current technologies, we have gotten very good at lowering the risk of dying of cervical cancer to a very acceptable level. That we may not ever get to a point where we have 0 cervical cancers in the United States. In fact, most of the cervical cancers that do arise are in women who haven't been seen by a gynecologist in the past 5 years. And so part of it is outreach to patients and making sure that they are coming in on a periodic basis to have the proper screening done. That said, if you are older than age 65, you have documented 10 normal years of Pap screening, and you are either currently in a relationship or not engaging in any new sexual relationships, your risk of dying of cervical cancer is sufficiently low that you could discontinue cervical Pap screening. That is not to say you do not have to go for a periodic gynecologic examination.
Because there are a lot of other things that are addressed in gynecologic visits besides just obtaining a Pap smear.
Absolutely.
Correct?
And it's not all about cancer. There's breast health, there's bone health, there's menopausal symptoms, there's vulvar vaginal health. So there's a lot that can be covered in an examination with your gynecologist.
What about women who've had hysterectomies? Do they still require Pap smears?
Bev, that's a very good question. And the answer is, in general, no. If you had a hysterectomy for benign reasons, not cancer, not cervical cancer, not cervical cancer precursors, then yes, you should not have Pap smears. The incidence of precancers and cancers of the vagina are sufficiently low that it is not beneficial to perform Pap smears. That said, a woman needs to understand that you can do a hysterectomy and leave the cervix in place. And so she must know whether or not that cervix is there. She also should know why she had the hysterectomy. So if the hysterectomy was for precursors of cervical cancer or for cervical cancer, then she should continue to have Pap smears of the top of the vagina.
Thank you for being here, Dr. Holtz. It's a very complicated topic, I think, the Pap smear and the new guidelines. So I appreciate your sharing your knowledge with our audience.
Well, thank you again for the invitation.